Good morning. Welcome to the workshop on attention and memory problems after transplant. I am Gina Londino, the Patient Access Manager for the New Jersey chapter of the Leukemia and Lymphoma Society, and I will be your moderator this morning. It's my pleasure to introduce you to Dr. Elizabeth Ryan. Dr. Ryan is an assistant attending neuropsychologist at Memorial Sloan Kettering Cancer Center. Together with the members of the Neurocognitive Research Laboratory, Dr. Ryan studies the cognitive and neurophysiologic aspects of cancer and its treatment, with a focus on improving cognitive problems. Please join me in welcoming Dr. Ryan.
Good morning, and thank you for being here today. Okay, so today we're going to talk about learning and memory problems after transplant. So, for many of you transplant survivors, you know that cognitive impairment can often follow stem cell transplant and can cause a negative impact on work, school, the ability to function socially, to attain career and educational goals, quality of life. There's also concern about impacting medical decision making and sometimes even capacity. And so the healthcare proxy may need to get involved, or the multidisciplinary treatment team may need to make an assessment about a patient's ability to be informed of their diagnosis, discuss the positives and negatives and side effects of various treatment options. Also, after stem cell transplant, if there is impairment, there's often the concern about what the etiology could be, because it may not have to do with the stem cell transplant. So ruling out non-transplant syndromes, whether it's an emotional reaction, a delirium, which is an alteration in consciousness, may be due to low T cell count after the transplant, seizures, allergic reactions, etc. So impairment can be caused by several factors. One would be the treatment before transplant. So total body irradiation is definitely a culprit there. Cranial radiation can also affect cognitive functioning, as much as the radiation oncologist will talk to you about targeted radiation. There's no way to target radiation so that it doesn't affect areas outside of the target per se. So you can get necrosis of the tissue, even tissue that you weren't intending to radiate. Inflammation can be caused by treatment. Obviously, emotional reaction to diagnosis, severe depression after diagnosis, during treatment, and certainly anxiety about prognosis. And certainly transplant doesn't protect against potentially other causes of cognitive impairment. Things like incipient dementias, which are more prevalent as people age. Certainly the rate doubles every 5 years after 65. White matter disease, which is often caused by cardiovascular risk factors, small vessel disease, and also intrathecal chemotherapy can also affect one's cognitive abilities. So there's a wide range of people that report cognitive impairment after transplant. Almost everyone talks about changes during the acute phase, whether it's fatigue or changes in cognition or both. And it can be fatigue causing changes in cognition. Sometimes the patient is aware that that seems to be the cause effect, other times not necessarily. This can also happen shortly after transplant. The objective neuropsychological studies, however, show mixed findings. Some report patients experience impaired functioning on our different cognitive tests before transplant, and there are inconsistencies whether there's improvement, decline, or there are domains that remain stable after transplant. So this wide variability of transplant in the literature quotes rates that go from 12% all the way to 89% after transplant. So it's quite a wide range. Pre-transplant, as I was saying, in that acute phase, most patients experience cognitive impairment in at least one area due to cancer treatments pre-transplant, especially in motor speed. Maybe it's due to a neuropathy, maybe it's just a reaction time slowing, but they might notice things like they're not able to write as quickly as they were before, or just if they have a neuropathy, not be able to use a pen or pencil as skillfully or type as fluidly as they did before. So obviously this includes a variety of hematological malignancies. It's not just one type of cancer. It's any of the folks that come for stem cell transplant. So whether it's lymphoma, leukemia, multiple myeloma, it seems to cut across the board whether or not people have cognitive impairment and to what degree. Similarly, studies have looked at allogenic and autologous transplant patients. And then there's some studies that have separated them out, only looking at one group or the other. So I thought the easiest thing for you to get an overview of the literature is to talk about a recent meta-analysis of 11 studies. So all of these studies were chosen because they had neuropsychological assessment both before and after transplant and included a sizable number, 404 patients. However, they found no significant differences in executive functioning. And executive functioning is just like what it sounds, like what the CEO does in terms of your brain functioning, overseeing everything, judgment, insight, problem solving, hypothesis testing. There were also no changes in attention, motor speed, verbal ability, verbal memory, visual spatial ability, or information processing. And the tests didn't measure every single one of these domains. Only executive functioning was measured in all of them. So the way the findings fell out is there were improvements, there were declines, there was stability. And stability is not necessarily a good thing because some of the tests, and it's just a fault of the test, that there are not necessarily comparable forms if you're doing serial testing. So some of the novelty of the test is broken after the first assessment. So presumably on the post-test or post-transplant, one might do better because the novelty is broken. They have some idea of what the idea is behind the test, and there should be a practice effect such that they might do a little bit better. So if they're stable, it kind of shows that that practice effect isn't there, and that can really be thought of more as a decline. And then also with mixed findings, there were some studies that had both improvements and declines. Improvements and declines were found in attention, executive functioning, verbal ability, verbal memory. Improvements were in visual memory. And as we talked about before, acutely there's some problems with motor speed, and post-transplant there seems like there's also a decline in motor speed. And even that sometimes is also just in cognitive slowing too. So when you have cognitive fatigue, your thinking may seem slower, and a little bit of slowness can really affect people such that they can say, I really don't feel like myself, I'm in a fog, that type of thing. There weren't that many differences based on treatment, but autologous transplant patients were more likely to demonstrate improvements in attention. There was no clear indication why that was. There were no significant effects of things like age, number of days post-transplant, or what percentage of patients got total body irradiation, and that having a poorer outcome. That didn't show up. Some of the studies included participants who had intrathecal chemotherapy, that cranial radiation, or other treatments that they didn't specify weren't at such great magnitude that they could then do individual analyses looking at the effects of just those things across the 11 studies. So here are some pictures of different neuroimaging methods. And here we have an axial view of the brain, and I want to draw your attention to the lateral ventricles. So this is really looking at a structural approach, and as the lateral ventricles get bigger, they're filled with the cerebral spinal fluid. The tissue has to get smaller. Here we have diffusion tensor imaging, which is looking at the diffusion of water molecules across the white matter. Functional MRI is when somebody is in the scanner doing a task, and we look at what areas of the brain light up and show activation or don't show activation. And it's really the comparison between the two groups that helps us judge what the pattern of activation might mean in the particular groups. It might mean that one group has to work harder to get the same answer. It might mean that one group is not showing activation, therefore they're doing poorly. It's not always straightforward. You really have to look at both groups. And then PET scanning looks at brain metabolism. So from our lab, Denise Correa looked at structural changes in bone marrow transplants after transplant. And she was able to see some changes in the left, the left middle frontal gyrus bilaterally, and the left caudate, which is a subcortical structure. So these are patients who had hematologic malignancies, who received high-dose chemotherapy with or without total body irradiation pre-transplant. And they were looked at neuropsychologically and with the MRI, looking at brain structure pre-transplant and at 1 year post-transplant. They looked at gray matter and ventricular volumes and cognitive function, and that was compared to the healthy controls. And as I said, there was a significant reduction in gray matter volume in the middle frontal gyrus bilaterally and in the left caudate nucleus in all transplant patients at 1 year follow-up. And this was not seen in the healthy controls, which would be the appropriate comparison group. And the caudate is basically also involved, it's part of the basal ganglia, it's involved in motor speed. The significant increase in the ventricular volume, which is from the axial picture I showed you earlier, if that ventricular volume increases, it means there's more cerebral spinal fluid there, and that basically means that it's pushing against healthy brain tissue, and then of course affects brain functioning. Similar brain structural changes were seen with patients treated just with the high-dose chemotherapy, so even the ones that didn't have the total body irradiation. So there are subgroups that might experience cognitive dysfunction prior to and 1 year following the transplant. The longitudinal assessment of the neuropsychological tests showed a significant group by time interaction on a time test of visual scanning and graphomotor speed. Again, that's going to involve the basal ganglia where we saw the caudate nucleus, and on a visual spatial or visual recognition task after, they looked at a certain figures, then they had to say whether or not they had seen them before or not. So this longitudinal assessment showed the significant group by time interactions as the healthy controls, but not the combined group, improved significantly at follow-up. So the combined group is the group with total body irradiation and not total body irradiation. So they were not improving. So here we're going to look at a lot of different potential causes in terms of trying to understand what causes cognitive decline. So there's a lot of things that go into affecting the blood-brain barrier, which is what allows, whether it's chemotherapy, radiation, etc., to affect the brain and brain functioning. Certainly surgical stress can be one, an inflammatory response to the disease. We talked about chemotherapy, especially intrathecal chemotherapy, that goes right to the brain. Then there's some other possibilities, such as people may have a genetic susceptibility. You've heard potentially about genetic susceptibility for dementia. An E4 allele of the ApoE gene may confer higher risk for Alzheimer's disease. It may also confer higher risk for cognitive changes in cancer patients. Hasn't been looked at in stem cell transplants as of yet. Advancing age, we know, affects cognition, and that's an area that our lab is trying to study, especially in terms of stem cell transplant at this point in time, because we've increased the ages of patients we'll consider for transplant. Neurotransmitter dysfunction can occur once cranial radiation, total body irradiation, or chemotherapy is in play. Neural repair mechanisms such as DNA damage, being able to repair shortened telomeres is also affected and can lead to some of the structural pathology we were looking at on MRI, and all that ultimately leads to cognitive decline. So whether or not treatment is associated with accelerating aging is not quite clear. However, we do have some evidence from our lab looking at other cancer groups and showing that some cancer survivors have an accelerated aging hypothesis where their trajectory is much more accelerated in terms of decline than cancer survivors that don't have this kind of dysfunction. And one reason for it might be, again, there can be a lot of things that I showed you on that schematic, but one thing that we did study and found was a significant factor was cognitive reserve. And by that, we mean that people that had higher pre-morbid, pre-transplant, pre-cancer levels of cognitive functioning tended to do better and withstand effects of cancer treatment. So it's one of those things that's sort of ubiquitous now in our popular culture about doing things to keep your brain active, whether it's through some cardiovascular exercise because you're getting blood to the brain, which is a good thing, whether it's being social, being active as a senior, that's important as well. So subjective problems are not always related to our objective cognitive performance, and that has to do sometimes with the insensitivity of our tests. Also, subjective reports could be due to other factors like depression or fatigue, and subjective complaints might really manifest themselves when someone's under a lot of stress or trying to multitask. And we know even for people that are cognitively healthy, they have a lot of difficulty multitasking. Their human brain is really not meant to do that. So there's different types of ways you can look at cognition. Screening tests tend to not give a full evaluation and really only broadly look at cognitive functioning, so they lack sensitivity and they may miss more subtle deficits. Here's a case example with a 52-year-old woman with a stage 3 lymphoma who had high-dose chemotherapy and total body irradiation, got an autologous stem cell transplant, and then had cognitive complaints of slow thinking, decreased concentration, memory difficulties, depression, and fatigue. And treatment concluded 6 months before her assessment. And after a comprehensive assessment where we're comparing her performance to other individuals that are age matched and education matched and gender matched, we can look at their performance on the normal curve and see what their strengths and weaknesses are in various cognitive domains and determine if there are impairments. And each neuropsychological evaluation can be tailored to someone's specific complaints. So if they're focused more in the memory area, we're going to look at attention because attention is very tied to memory, and maybe less so at something like motor speed. So we select the tests that are going to yield the most comprehensive understanding of a person's difficulty. And here are all the different cognitive domains that we've touched on as we've been talking. Usually the assessment's about 2 to 3 hours. The time spent depends on what information is being sought and also the patient's fatigue. It might need to be spread over a longer period of time. If they're fatigued, there might need to be more breaks. So in the case example I was telling you about, the woman was generally high functioning. There was no obvious contribution of other medical conditions. There was a psychiatric history that potentially contributed in terms of depression in the context of different stressors, including her diagnosis of cancer. So with testing results, we found attention was mildly impaired, psychomotor speed was mildly impaired, verbal memory was mildly impaired, but other areas were not overtly affected. And so there was also the potential contribution of depression. So the results are used to confirm a diagnosis because she had a subjective report of these. to talk about the weaknesses, the impairments that we saw, and then also strengths that she can use to compensate for the weakness, and then guide rehabilitation and document changes in functioning over the long haul in future evaluations, and determining what specific compensatory strategies might help given her particular impairments, and what specialists or services we might recommend. So in terms of cognitive rehabilitation, there's basically two different things that we're looking at. One is compensatory, where we're training patients to develop strategies and behavioral changes to augment function. These can be things as simple as to-do lists, calendars, personal organizers, and then they can get more complex too, because we can use some technology to help them manage their lives better. We also sometimes have to think about the person-environment fit, because sometimes people cannot return to work because today's workplace is rife with the need to multitask, and often attention can be affected, and it's very hard for people to function at an optimal level in a multitasking environment with a lot of distractions. And sometimes there's really no way around environmentally engineering a job such that the person can do it. The other type of rehab is restorative, and that's really more drills. So you'll see ads if you watch PBS for programs like Luminosity. There's a bunch of others as well. And basically they're drilling you on various tasks. And really the question and concern among researchers is how that generalizes to other tasks and your ability to function day to day in terms of household management and at work. And finally, there are some pharmacological interventions as well that can be used, particularly with attention and fatigue, and certainly with emotional dysregulation. And that's what I have for you today.
Well, thank you, Dr. Ryan. We will now take questions, and this session is being audio recorded, so we ask that you please use the microphone when asking your questions so everyone can hear you.
Have there been long-term studies, follow-up studies? I know that these are a year post-transplant. Have there been any studies following the improvement in attention, memory, processing speed?
Looking, I would say, like, if you wanted to look at something you'd be probably interested in, like looking 5 years out or 10 years out. No, those haven't been done. I think that probably the place best suited to do something like that would be Fred Hutchison, because of the amount of patients and the throughput that they have. But again, it's been such a fast-paced growing field, and so many more patients have been offered this treatment. So it's hard to get a research sample that's willing to do it and a matched healthy control sample, and then either look at the cognitive testing, but usually an ideal is to also look at neuro imaging as well and brain structure.
Have you ever had any patient bring forth to the table an issue that a close family member has been exhibiting, although they've moved on as a patient and they compensate and so forth? Because I'm dealing with my husband right now, who is showing all of these issues as far as cognitive response and deficits. And as I think back, my transplant was in 1993, but I remember, and I've had several cancers after that, I can remember back things that he's done that have shown.
So he did not have a transplant?
No, I had the transplant.
You had the transplant, but he's showing difficulties. Well, you know, of course, you know, the number one reason that people have cognitive impairment is dementia. So, you know, age is the biggest risk factor for that. Family history is a risk factor for that. Cardiovascular problems are a risk factor for that. So if you find somebody has changed from their baseline, you want to figure out if, by going to see a neuropsychologist, if it's within the bounds of normal aging or not. Because almost all the dementias are progressive declines. So the earlier you can get into a clinical trial or some type of treatment, the better.
Hello. When would you recommend having this cognitive testing done? What kind of symptoms or what should you be looking for, and when do you think it would be beneficial after transplant?
Yeah, that's a really good question, because I've had patients who've come to see me after transplant, and there are some ways we can gauge what their premorbid function is, but it's not as easy as if we saw them pre-transplant. The pre-transplant period, as you know, is a very busy time. And, you know, sometimes when we're trying to approach people even for research studies, they have so much going on with workup and treatment in that phase before transplant that they don't want to add another thing to it. But ideally, that's the best time, because if there are any problems post-transplant, a year out, 18 months out, we do have a comparison. And for instance, if someone is not able to return to work, they are better situated for, if they have a private disability policy, for being able to get disability based on cognitive dysfunction, if we can look at the comparison of pre and post cognitive functioning.
Hi there. Is this the type of testing, though, that no one recommends for you? That's not like, oh, you had your transplant, you should go get cognitive testing?
Yeah, exactly.
If you do ask for it, are they going to recommend, after you do your 2 to 3 hour test, and they're like, well, obviously you have some kind of cognitive dysfunction, here are things you can do. Is that part of the package? Is this...
No, not necessarily. I mean, there's some people where... they're totally fine. So that's good news. And we just want to make sure that later on there's no decrement in their functioning. So in that case, there's not really going to be a recommendation that there's anything that they do.
So when you say totally fine, if somebody was this high functioning and then they're down to normal, that's considered totally fine?
No, that would be a decrement.
Okay, so if that was a detriment, would like, I actually went to Denise Correa, and I'm not happy with her, and I can't believe that she's the one that did this studying. I'm shocked. But she didn't follow up. She didn't give me any of these exercises, and she kind of screwed me over because she didn't do this. So, yeah, I mean, I was studying for the bar exam, and she didn't write a note.
Oh, yeah, and especially with
to get accommodation.
Yeah, with the bar exam, you can get accommodation.
Yeah, no, but with the note that Denise wrote, they put me in a room with people, even though I said, well, whatever, I mean, no one needs my whole life story here, but it was not helpful at all. Like, just really, really not helpful. So is this something, though, that if you go for if you go for a cognitive testing, do you get cognitive rehabilitation? Is there something that doctors are doing?
Well,
or is this just strictly for research purposes? Like, we're really suffering with this. I mean,
we have a behavioral brain health program at Sloan. There's a neuropsychiatrist and 3 neuropsychologists. So there are 2 others besides the one that you saw. But I could talk to you about it afterwards.
Are you looking at the cause of the cognitive decline being the administration of the stem cells or the administration of the pre-transplant chemotherapy, or a combination of both?
The meta-analysis I showed you was trying to look at only taking studies that had pre and post, and basically the results were very inconsistent. Some improvement, some decline, some stable. In some of the studies, there were not enough studies to look at individual things like what's the effect of intrathecal chemotherapy, what's the effect of total body irradiation. It seems like with autologous stem cell transplants, there is improvement in attention following transplant.
So it's the preparation that is more responsible rather than the administration of the stem cells?
It's hard to really say at this point because there's so many factors combined, because even the cancer itself is causing inflammation, is causing DNA damage before you have things crossing the blood-brain barrier, being introduced into the body. I'm sorry, it's the best answer I can give you.
Hi, I'm 2 years out of my stem cell, and in reference to what she was saying, I feel as the doctor oncology department, they're in charge of seeing that we are saved and cured from our disease, and that's their sole concentration. So after you have a few good reports, your scans are good, but we keep saying the same things to our oncologist about our neuropathy, about our mind not being who we are. I was a high-functioning person in a surgical dentistry thing, always going. I couldn't multitask anymore. We don't want to go into my whole story, but anyway, a lot of us know we're not ourselves. We want to get back to what we were. But as far as the doctor's end of it, I took it as, okay, once I was at 2 years, it's like I asked him, what do we do now? Then I got okay, well, now we'll work on the neuropathy. We'll go to the physical therapist. We'll do some stimulation. Okay, so we were doing that. Also, I had the cognitive functioning test. The neuroscience person I see, I'm from Pennsylvania, but we're doing follow-ups. Mm-hmm. We started like a medication, which you mentioned about depression. I'm a positive person. I'm thinking, I'm not, heaven forbid for the people that are depressed and get into this situation, because I was a very positive person. But they say those things help with clarity and getting you more focused. Try something like that. And also the testing now, I have to get back to her. I have a follow-up at the end of this month. But I think then I'll know to ask about more of the behavioral things to try to help stimulate, or what you're saying, like the testing to help. I already did the testing, and we know their things are weakened from where I was, but I don't know if that's making sense to you, but I think you have to find somebody that, make sure you get a follow-up. Make sure that you're not yourself, so find out what all is going on, find ways to help. Where you guys are in the department, I think that's what you were meaning about studies as 5 years out. You only see these people initially in our trauma time of, pre-transplant to, maybe a year out. Is that correct?
That's really more in the research setting.
Yes.
But if someone complains, then we'll get a referral no matter how far they're out. And so I've seen people that are several years out and they need to be on disability. There is no way that they can function at their previous level of occupation.
Yes, and that's what I'm finding. And a lot of you too, I'm in that position where, to find a job, even for me right now, McDonald's would be way too stressful, which was never even a possibility. And I'm thinking, gosh, can we even do that? So that's where, I think it's good to have people have this information to know if you're not getting answers, go somewhere and ask questions that we didn't know to ask before. Mm-hmm. I didn't know to ask these questions. So, okay. Thank you.
Hi. If you have to have a second stem cell transplant, does it get even worse, your cognitive?
Yeah, I actually, anecdotally, I can tell you I've seen a handful of people, and again, I've seen different findings with people that have had more than one transplant. It's not always, a sure thing that it will go one way or another. So there is variability with that too. Again, really probably has to do with things that we talked about that we're still looking into that are kind of the causative factors of what's causing the cognitive problems to begin with. Some people have better repair mechanisms, DNA repair mechanisms than others. Some have genetic susceptibilities. So it might have something to do with that as well. Also, maybe how things went the first transplant may be predictive of the second transplant. Again, there's really no research literature on that because it's hard to find a group unless you have, a multi-center study because everybody has, not many of those folks.
Hi. One thing I've noticed since I had a stem cell transplant and also was on a maintenance drug after multiple myeloma is that my hearing was impaired. And I'm going to Costco next week and I'm going to get hearing aids. And I've found that trying a hearing aid helps with the clarity. And, I think that can improve just hearing better can improve my IQ a bit, so.
Oh, absolutely. Yeah, because you're missing information. Yeah. Or sub-vocalizations.
Yeah. And the person who was helping me with the test said that the outer cilia are often affected by chemo, and they are impaired, and that those are the cilia that pick up the high frequencies. So I have a better, I hear lower voices better than higher voices. Anyway,
that's an excellent point, and thank you for bringing that out, because really that's not always a recommendation for people, but it certainly can be a contributory factor. Yeah.
I don't really have a question. What I have is almost a suggestion. It occurred to me while listening to all these different things that we all have different issues, and you say that the studies haven't been done. And I'm not saying that this should be a study because I know it has to be controlled, but possibly after these, where we all have these problems, obviously, and we've all had bone marrow transplants, why don't we spend 20 minutes writing down what bothers us, and then you take it and go further with it, and the next time you have one of these, you have more of an idea of what every one of us is dealing with.
Yeah, actually, I think that would be a great idea. I was thinking about having people, do the sort of hand raise
But
thing.
not like this one, which is general, more like a
more specific.
More specific for
Right.
you, that you have, my particular memory problems are verbal. I can't remember a very simple word. I could remember a very difficult word, and I also have a very strange situation where my memory lapse is somewhere prior to my actual bone marrow transplant. But what that is, who knows? But, we're all dealing with something completely different, but we're all the same.
Yeah.
And
there's quite a lot of variability that
also
with research are trying to kind of look at group effect. Not
but I
look
don't
at
know if it
individual
needs to be a
variation.
research thing. I just think it needs to be when you're here, you need to
target the audience to what their concerns are. Sure.
I don't know.
Thank you. I don't want to be disabled, and I don't want to be labeled disabled, and I think maybe a lot of people don't want to be. I think there should be a space between that and being able to go back to work in a multitasking environment with a lot of distractions. What accommodation can be made for employees so that they can go back to work, and then as they are able to do more, they can try to reach the level that they were at before. Who can be an advocate for us with our employers? Because everything you've talked about makes a lot of sense, but there's no putting this into a simple way to explain it to an employer who simply, it's so much easier for them to say, well, you've got to go on disability. I can't use you this way. I mean, who can advocate for us?
Well, I think one of the starting points is looking at the legal aspects of the Americans with Disabilities Act and the need to make accommodations for people who are returning to work after a catastrophic illness that has also affected their ability to perform their job in the same environmental structure as before. Because perhaps it's really just a function of environmental engineering. So instead of working on a floor with a bunch of cubicles, you really need to be in a room with a door that you can close. And that's simple. It might be difficult at your place of employment to get that through, but eventually one would hope you could.
Hi, I have especially short-term memory problems, and I'm just wondering, I had my transplant 12 years ago, so I don't know how much is the transplant or just the aging process. I blame everything on my disease, but is there a way to know that? And see, I can't remember the other part of my question. I should have written it down. I know it. So if I've never had cognitive testing, and how do you determine whether or not that's something I should do, and what would it benefit?
What I was explaining is when we assess someone, we're comparing you to a normative group that's your age your education, your gender. So we know how they should function, and we look at you in comparison to those people. And then from that, we can see what you're talking about. This short-term memory is sort of things like you walk into a room and you forget why you went there. And a lot. What?
It's normal for a lot of people, like my friends who've never been sick, say, like after age 40.
Yeah, exactly. So it's looking at things like, compared to other people that age, is it happening more for you or less for you? And, and then also seeing if there's anything else that could be contributing to it besides your medical history. Maybe there's some other thing that's more recent that's also a contributor.
So what about cognitive testing? That's the second part of my question. How do I know if I should do that, or how do you go about doing that? Is something your doctor recommends? Or?
Yeah, or you could find a neuropsychologist or a psychiatrist, or ask your oncologist. You could call, the Leukemia and Lymphoma Society, the American Cancer Society. You can look on the Survivorship websites.
Hi, I just wanted to go back to the young lady in the back. Lindsay she spoke about the bar exam, and you said you would speak to her privately. But everything today talk about the testing, and I think without the testing, we all know that something's wrong with us. Mm-hmm. And but what is it what is the rehab? What do you do about it? I see the to-do list, calendars, but isn't that just you're coping with it? But isn't that just a Band-Aid? What do we do about it?
So right now, it breaks down to compensatory strategies, restorative strategies, or pharmacological strategies. So in the pharmacological strategies, a lot of people are adverse to that because they've had a lot of medications already. So those might be things like, someone talked about an antidepressant. They also might be things like stimulants to help perk someone up and help boost their attention. In terms of the compensatory, I gave you very simplistic ones here. There are also programs that build on each other week after week. Sometimes they're done in a group format, sometimes they're done one-on-one. If they're done one-on-one, they're really looking to address a specific problem you have that you want to ameliorate, and breaking down the steps to go about fixing that. And then some of the restorative programs are more drill-based. And the question of those is whether or not they generalize. I've had some success with those generalizing, primarily because people had to come up with a strategy to do the task. There was no explicit strategy given, and then they started using that strategy at work in their day-to-day life. So that made a difference for them.
So you would do this personally, one-on-one with the neuropsychologist?
Mm-hmm. Or our occupational therapy team also works with this as well.
Okay, thank you.
Sure.
Hi there. Everything you reported on refers to pre-post transplant. I think particularly some of the questions here are indicating that, well, at least to me, that people are experiencing what I think most of us refer to as chemo brain. When you mention transplant, are you really talking about the cognitive impact of chemo or the cognitive impact due to receiving stem cells from someone else?
Well, this woman also really asked about that as well. It's really hard to disentangle some of that because, the one study I was talking about with the high-dose chemotherapy, basically there was no difference between the two groups, the one that had total body irradiation and the one that didn't. They both had stem cell transplant. So was it the high-dose chemo or was it the stem cell transplant? That study is probably not designed to answer that, but it did show structural brain changes and less so problems on neuropsychological testing, which could be the insensitivity of the test, or it could be that really what they just showed was not much improvement on the test relative to healthy controls. So it's hard to say because usually, designing these tests just to look at one thing, what I tried to give you is the broad overview of the research to date compiled together. But it's hard to say. And chemo brain in the literature, in the popular literature, has just become anyone who's on chemo. But what I tried to show you with that schematic is before neurotoxic chemicals are involved, even with the cancer, changes are already occurring that we can see. So for example, in breast cancer, pre-surgery, 1/3 of breast cancer patients are already showing cognitive decline. So that basically speaks to DNA damage, cytokines, inflammation, all kinds of other things affecting the brain. And that's before adjuvant chemotherapy.
So if I'm understanding you, you're saying some of this is attributable to the disease as opposed to the cure.
Yeah. We don't know exactly how. We have, like a list of 10 possibilities.
Have you ever looked into the cumulative effect? I was diagnosed in 2004, treated with 5 rounds of intensive chemo, did not have a transplant. Then 3 years later, relapsed and did have a transplant with myeloablative chemo.
Yeah.
And I don't know if there's a tipping point somewhere.
Right, and you also know subjectively yourself how that went. Yeah. So, all right. Well, thank you very much.
Thank you, Dr. Ryan.